Morning, everyone, and thanks so much to the chairs for the introduction. I am Dr. Amy Ward from UCT South Africa and the Khayelitsha Research Clinic VUCA in Cape Town. Today I'm going to talk about long-acting antiretrovirals for both treatment and prevention of HIV, long-acting at long last. I'd like to declare that my institution, UCT, is currently funded by Gilead to conduct the Purpose 1 trial, and I serve as site PI at the VUCA Research Clinic on Purpose 1. I'd also like to declare that I am a prevention person, and while this talk will include a bit on long-acting HIV treatments, I will focus on my focus, which is PrEP, specifically lenacapavir and the findings of the Purpose 1 trial. A brief overview of today. So we'll look at long-acting biomedical products, and these are not only the injectables. I've included the vaginal ring as well, so things that don't have to be dosed daily, available for HIV treatment and prevention. Available is a contentious word because, as we know, long-actings are not really available on our continent. We'll look at the Purpose 1 study, and then I'll give you a quick view from VUCA on what PrEP studies mean to young people living in Khayelitsha. So let's get into the long-acting antiretrovirals. Long-acting antiretroviral treatments are all in the currently, I've just stuck to the registered medications that have been registered somewhere in the globe for treatment. So all of them are in the injectable form, and the monoclonal antibody, I'm going to try to say it, ibalizumab, may also be given as an infusion. In terms of the drugs that we have, so it's cabotegravir LA, ropivaline LA, lenacapavir, and the monoclonal antibody. The Cabotegravir and ropivaline LA are quite well known to us, and they were reformulated into a long-acting formulation, Cabotegravir being an integrase inhibitor and ropivaline being an NNRTI, and both of these class of drugs are really familiar to us in the HIV management space because they've complemented our backbone in all our heart regimens. So we're quite familiar with that class. Lenacapavir is a first-in-class capsid inhibitor, and I'll get a little bit more into that when I present the Purpose 1 study. And ibalizumab is a monoclonal antibody, which is a humanized antibody protein that binds the CD4 receptor, thus preventing HIV entry into the cell and doing all its functions and replications. So to look at the treatment regimens, Cabotegravir and ropivaline need to be given in combination with each other in order to have an effective treatment regimen. This is then dosed monthly or 2 monthly. And it is licensed for people living with HIV who are already suppressed on a daily oral ART regimen. Lenacapavir is a 6-monthly dose, and the monoclonal antibody a 2-weekly dose. And just important to note here that these must be taken in combination with other ARVs, usually a daily oral ARV regimen, and this is because it's licensed for people living with a resistant HIV infection, so they need a complex ART regimen. If we look at access and registrations across the globe, it's quite a bleak outlook. Cabotegravir and ropivaline LA registered for treatment only in one African country that I could find evidence of, and that's Botswana. Otherwise, registrations are really isolated to Europe and the Americas. And availability is sort of really only to a handful of countries in the global north. So again, this is not available in our continent. If we look at long-acting ARVs for HIV pre-exposure prophylaxis, we have Cabotegravir again, the very same Cabotegravir we just discussed in the treatment slide, except in the context of prevention, it can be given in isolation on its own as an intramuscular injection, so quite a deep injection into the muscle, and it can be given 2 monthly, except for the first 2 injections, which need to be given a month apart, and protection is then conferred about a week after the first injection, and it's been licensed for adults and adolescents at risk of acquiring HIV through sexual intercourse who weigh at least 35 kilograms. Dapivirine I've included here is a NNRTI that was formulated into a vaginal ring, and I thought this was just quite an exciting new development because it's a user-controlled intervention for HIV prevention. So they've put this in an RTI, in a vaginal ring, which is placed into the vagina, and the drug is dispersed and acts locally. The ring needs to be replaced every month to ensure that the drug levels are sufficient, and protection is conferred only after it's been in place for at least 24 hours, and it must remain in place during the sex act. So obviously this does raise some concerns for the user. It's a vaginal ring, so it can only be used and therefore is only licensed to protect people who were born assigned female sex at birth. So for women who are at risk of getting HIV through vaginal sex, it's not going to protect against transmission through other routes and other sex acts, example, anal sex. Important, all of our long-acting PrEPs and any PrEP really is recommended as part of an HIV prevention package, which includes barrier methods, STI screening and management, and risk reduction counseling. Okay, you can see Africa over there. On my slides, you can't see Africa. So I've put together these slides just to try to illustrate the global picture of registrations and availability for Cabernet and the DAPI ring. The DAPI ring is registered for HIV PrEP in South Africa, Namibia, Botswana, Zimbabwe, Zambia, Malawi, Eswatini, Lesotho, Kenya, and Uganda. And registrations are being considered in Tanzania and Nigeria. And I've tried to present availability as number of initiations, and I got this data from PrEP Watch and used this cool thing on PowerPoint powered by Bing to make the maps. So we can see that while the registrations and availability are there, they're still quite limited and primarily through research and demonstration projects. South Africa having 790, Eswatini 152, Zambia Zimbabwe in the lead with 858, and Uganda with 60 initiations. So really small numbers still from this data. And then I also read that marketing outside Africa is apparently not going to be pursued. So really this is going to be isolated as an African intervention, which I thought was interesting. Okay, if we look at Cabernet, it's got a much more global presence with registrations progressing across 6 different continents. Availability is presented here again as number of initiations per the AVAC data. And again, if you're outside of the US, which has 11,000 initiations, it's really still limited to access via demonstration and research projects, with really small numbers of initiations in Southern Africa and the South. So now let's look at the Purpose 1 trial. This is the first trial I actually got to engage with adolescents, which was great. And it tested lenacapavir as HIV PrEP in cisgender adolescent girls and young women aged 16 to 25. The study is a double-blinded, randomized control trial and is being conducted across multiple sites in Uganda and South Africa. I'm going to share the results now from an interim analysis of the data done earlier this year that led to the Data Safety Monitoring Committee recommending that everyone on the trial be unblinded to their treatment assignment and offered open-label lenacapavir due to the staggering efficacy results that we received. So here is len, or lenacapavir. It is a first-in-class capsid inhibitor, and so we haven't really used this type of drug before. It's obviously registered for treatment in certain conditions, but it is the only capsid inhibitor that we are currently using. It acts at the capsid, which is an integral structural component of the HIV virus, which is involved in many of the life cycle steps of the virus. So you can see here that len is actually acting at the nuclear transport level, viral assembly level, and the capsid core formation. It's given as a subcutaneous injection, so a little bit of a shallow injection under the skin, and it's given 6 monthly, so twice a year. Important to note here that a dose is actually 2 injections of 1.5 mils each, and your first injection must be accompanied by an oral loading dose to get the drug levels up, so 2 tablets on the day of first injection and the day after first injection, and thereafter it's just your injections every 6 months. This is a overview of the Purpose 1 trial protocol plan and the numbers as they played out. Is it projecting? Okay, good. So we started out with interested volunteers and we consented them, and everyone underwent HIV testing. Those that tested positive in the purple or pink really helped to fuel what we call the incidence phase of the study, and bloods were tested with a recency assay, which assisted us in determining how long these HIV infections, or how old these HIV infections were, how long had these women been infected for. Everyone was referred for care, and then they ended their study participation. Those women that tested HIV negative were divided at random, so randomized into 3 different groups. Group 1 to receive the lenacapavir injections every 6 months. Group 2 to receive TAF tablets every day orally. And Group 3 was our comparator arm, our standard of care, Truvada or FTDF tablets once a day. Each group got a placebo to match the orals for the lenacapavir group and to match the lenacapavir injections for the oral groups. The reason to give placebos in trials is to ensure that there is blinding of both the participants and the care providers, so we avoid bias in our data. So these groups were then followed up from day 1 over a year, and we looked at safety outcomes, tolerability of adverse events, and we also did HIV testing. The results from the 8,090-something women that tested for HIV in the incidence phase gave us a background HIV incidence rate of 2.41 cases per 100 person years. So this would be what we were looking against. Are our drugs effective to bring this rate down? The table shows the analysis of the randomized blinded phase, the 3 groups of women that entered the randomized blinded phase. And we look at baseline characteristics to ensure that the groups are comparable across all other components except the treatment assignments. So we can see here from the table that the groups are really comparable across race, education level, marital status, STI infections, PrEP use, and HIV testing. There were slightly more adolescents in the LEN intervention arm, although overall the age was comparable across the 3 groups. If we look at the analysis of the HIV infections over the first year in the 3 groups, you can see the pure blue donut there is LEN or lenacapavir. And we had 0 infections in women who received lenacapavir over this year, giving a rate of 0 per 100 person year. So it was 100% effective in preventing HIV infections in those women that received it on the trial, which is really incredibly staggering. If we look at our comparator group, Group 3, we had 1.69 HIV cases per 100 person years, and so slightly better than the background incidence, which we remember was 2.41. And if TAF was really not very different to the background incidence with 2.02 HIV cases per 100 person years. It's important to note here that the majority of people did receive their LEN injections or placebo injections on time. Is that back? Sorry. Obviously, safety was a very important analysis as well. So as far as we can tell, data to date shows that lenacapavir as well as FTAF were really well tolerated and found to be safe. So currently no safety concerns. And as this trial quite revolutionary, it was quite revolutionary in that it allowed pregnant women to continue as long as they opted in. We've seen that pregnancy outcomes in all 3 groups were in keeping with those expected for the age group. So at present, we really don't have any safety concerns around pregnancy or any other safety issues. So where to from here? I was going to change the slide because I was looking late last night for the Gilead Access statement, and I saw a wonderful press release that Gilead has, as of yesterday, signed 6 voluntary licensure agreements, pre-registration. So just get on the socials and see that, guys. It's actually amazing. The purpose is not just purpose 1. There's a bunch of purpose trials that are really trying to do this prevention with purpose mission. And a couple of weeks back, purpose 2, which is our sister brother study of purpose 1, showed similarly really great results in preventing HIV infections in MSM and transgender people and gender non-binary people. So we were just we were informed that we were waiting for this data before registration applications. So now that this data has been released and is as, it's not 100%, but I think there was a 96% reduction in HIV infections, which is also amazing. The registration applications, as far as we know, are imminent. And Gilead does have an access strategy on their webpage, but also please go check out the news this morning because the license agreements have been signed. So a quick view from VUCA. So this is, we only opened last year, and this is our World AIDS Day event where we went marching around Kailicha with a troop of Jompops from, where were they from? Kiasa, I think. I don't know. It was amazing. We had a great time, and it was a great study to start with. So recruitment for Purpose 1 at VUCA, we had a bunch of people interested in PrEP from previous PrEP studies and observational protocols. We engaged with our community organizations and we used word of mouth, but as Bule says over there, she's our CLO, there was absolutely no shortage of volunteers interested in injectable PrEP. We had an oversubscribed volunteer base for Purpose 1. On the ground perspectives of injectables for HIV PrEP. So these are just a few quotes from people who had engaged with the trial in our community. And I think the last statement, protection, empowerment, freedom, just sums up the really great perspective and sentiment on the ground about a long-acting injectable for HIV prevention. I just wanted to show you guys this. These are the 3 infographics we put together to help participants choose when they get unblinded. Should they carry on with LEN in the LEN-OLE or open label phase? Should they stop injections and stay on the study and take the PK tail phase? Or should they end study participation? And we color-coded it for them and try to make it nice and simple so they understand their choices. And you kind of go through all 3 with them, and then they just stare at you and they just say, obvious, it's the pink. Everyone wants LEN. So it's really, really great. There were a few concerns around this injection for HIV PrEP. Obviously, a lot of women are concerned about pain for injection, but I mean, it's an injection. Every injection is going to hurt a little bit in the beginning, and we really didn't find any ongoing concerns about pain. There were also initial worries about nodules after injection, but it hasn't amounted to, anecdotally, it hasn't amounted to anything of material concern at our site, and I think the data is there to support that. Okay, so what can you do as young people? I've heard you guys like memes and stuff. I hope you guys know this Mudeng creature, because I just Googled what's new on the memes, and apparently this hippo is very popular. So you can just keep calm and listen to Mudeng. You stay active in the HIV space. Just keep doing what you're doing until you get what you need. You guys are great. It's great to see all these young people out here and all our slightly older people here to support the young ones. Stay informed, as we learned from last night's press release. It's a rapidly evolving and changing space, and Mudeng highly recommends that you follow some good resources. PrEP Watch, powered by AVAC, is amazing, and Spotlight is also a great health journalism in South Africa and also the region, and you can follow them. I've put the links there. So in summary, we are here in the era of long-actings and alternative methods of delivery. Options have been trialed and registered for both treatment and prevention. LEN has been shown to be highly effective and safe and well-tolerated in HIV prevention. Access is our priority work area, and all of us role players need to stay active to ensure equitable access. Just like to acknowledge these role players and sources used. Thank you so much.